Hello, my name is Maria Filomena. I am professor at Faculty of Psychology and Educational Sciences at the University of Coimbra in Portugal. And it is really for me a pleasure to be with you in this final conference, thinking about the impact of high parental conflict in children. To think about that, I'm going to share with you my presentation. And when we think about the child in the high conflict parenting relationship, one important thing that we need to think about is about the neuropsychological impact of that high conflict. So I'm going to organize my conference around three topics: how the high conflict impacts child development. I'm going to speak about chronic stress and about adverse childhood experiences. After, I'm going to think with you about the impacts, not just short-term impacts, but also long-term impacts. And finally, I'm going to think with you about not just risk, but also protective factors, and about how can you and me prevent, reduce the impact when we focus in parents and using different kind of intervention, including psychoeducational programs. And I'm going to speak about one program, Crianças no Meio do Conflito, that means children in between the conflict. So when we speak about high conflict, we are speaking about what? We are speaking about the conflict between parents that is very frequent, that is intense, or intense with aggression, or intense with what we call the silent treatment. The silent treatment is when the conflict is not evident, there is not aggression, but there is a threat, is a nonverbal conflict. And it's not enough to have a frequent and intense conflict to speak about high conflict. The conflict needs us to be poorly resolved. That means that is a conflict that is destructive, that is hostile, and that is present in what we call acrimonious parental separation. So this kind of conflict configures what we nominate as an adverse childhood experience. And why it is this high conflict is an adverse childhood experience? Because extreme stress that child is exposed, because she is exposed to a high conflict relation, is a stress that involves a long-lasting response, and when there is not relationships that could buffer that stress in child, so child doesn't have an adult that she could turn to in order to buffer what she is feeling. When we speak about that, we are speaking about toxic stress. Toxic stress is a stress that is strong, is frequent, is prolonged, in what means the activation of the body stress management system. This stress is different from what we call total level stress. That is a stress that have, of course, the potential to negatively affect the architecture of the brain of the child, but because it occurs in limited periods of time, is not prolonged in time, it allows the brain to recover. So what happened with toxic stress? Toxic stress damaged. Toxic stress weakened the bodily system and the brain architecture. So it's not the brain, just the brain functioning, but that's the brain structure. And so this toxic stress has lifelong repercussions in child development. How this happened? This happened because the stress activates one axis and one system. It activates what we call hypothalamic, pituitary, adrenocortical axes that produces cortisol and activates a system, the sympathetic adrenomedullary system, that produces adrenaline. So what we have cortisol and we have adrenaline. This chronic stress strengthens the neural connections in the amygdala. So if the neural connection in amygdala are stronger, that means what? Means more cortisol. And as you know, amygdala is involved in fear, anxiety, impulsive response. So the child acts in what we say a survival mode. When this happens, the brain function weaken. Why? Because electrosignals in the hippocampus, that is critical to both learning and memory, as well for stress response regulation, is weakened. So all the regions in the brain dedicated to reasoning, planning, behavioral control have fewer neural connections. So we have higher connections in amygdala and fewer neural connection in these regions of the brain involved in the learning, planning, and behavior. So we face a very high change in the brains of the children, not just because our brains, but because they are brains that are still developing and growing. So what is the impact? The impact is that children may feel threatened by or respond impulsively to situations where no threat exists, or the children may remain excessively anxious long after the threat has passed. Another implication is that we can face epigenetic alterations. So are not only alterations in the brain structure, brain functioning, behavior, but are also alterations in the genes. It's why we can find a latency periods at short and medium term that we don't see impact, but you only see the impact when it manifests in the adult age with psychopathology. And of course, when we think about these impacts, we need to think about impacts in different areas of child development. I'm going to use this guide that is done with collaboration of Professor Gordon Harold at the University of Sussex. And based in that guide, we can think about the impact in different areas of children development. So when we think about emotional development, we found in children with 6 months symptoms of distress, with children up to age of 5 crying, and from 6 to 12 years and adolescence, we found emotional distress, low self-esteem, depression, and anxiety. When we look for behavioral implications, we up to age of 5, we face crying and acting out, and with all age, we found externalizing problems like behavioral difficulties, antisocial behaviors, and conduct disorder. In what concerns social and interpersonal relationship problems, we can find negative peer relationships, but also in future, relationships that could be destructive in what concerns the conflict. Why? Because the conflict is going to be repeated across generations. So I mean, interpersonal violence is also one possible implication. In the academic domain, we found academic problems and learning difficulties. We also talked about the impact of cortisol and adrenaline in the brain. And of course, when we look for long-term mental health, depression, anxiety, post-traumatic stress disorder, substance misuse, interpersonal violence, psychopathology, with implications like low employability, they could also be present. But also physical health. These children, when they became adults and elderly, they have more aging-related memory and cognitive deficits. They could have more cardiovascular problems, stroke, gastrointestinal, diabetics, metabolic and inflammatory diseases. So we need to look for factors that we need to change. And when we look for these factors, they are factors that justify why a child that is in a high conflict parenting relation has some problems and another one doesn't have. Why? Because one of the children have more risk factors and they have less protective factors. Poverty and economic pressure, parental mental health, and alcohol and substance misuse, the parenting, harsh parenting, and parent-child hostility, the gender. Why? Because fathers are more likely to withdraw or to be hostile with their children and mothers. When these risk factors are present, of course, there is a cumulative risk that increase the impact of high conflict relationship between the parents. But we have also factors related with the child, the age. When they are younger, they blame more themselves. What did I do? When they are older, they display more behavior because they put the problem more in the other. What did you do to me? More self-regulated and more positive children, of course, they are more protected against the impact of high conflict. And in what concerns gender, we know that girls internalize more than boys. So what happens is that boys see the conflict as a threat to themselves. So they have more externalizing problems. And children that have lower levels of stress hormones, like cortisol and adrenaline, they are more resilient, so they are more protected. And of course, the social support of child, not just peer friendship, but also a supportive adult outside the family or inside the family that could protect that child. So we know that the more important protective factor is the child have a safe and dependable relationship to turn to support. Even if in children who may otherwise be highly vulnerable to stress system activation. So what can we do to prevent or reduce the impact of high interparental conflict on children? We can focus in parents, not just can, we should. Why? Because we need to change parents relate to each other. We can use more therapy or counseling, or we can use psychoeducational programs, or family mediation, or information and advice. What we know is that all this kind of intervention, they have efficacy if they are face-to-face or online or using the phone. They should be community-based and they need to be volunteer. If not, parents will not be open to do change in themselves, not in the other, not in child. So in Portugal, we use a program, a psychoeducational program, that is the first step when we work with families with high conflict in parenting after a divorce or during the divorce or separation. It used a very important and evidence-based American program, Children in Between program from Dungarten. So we use in our program the video scenes of the Children in Between program. Is 8 weekly 2 hours session program. It can be used in the group format face-to-face with 10 participants or online with 8 participants. We never involved couples, former spouse in the different. We always use a different group if you want to work with the 2 parents, not just with one. And this program is led by 2 group leaders that have to have a 3-day training and supervision in the program and close supervision during the implementations. So what is the goal of this intervention? The goal of this intervention is to develop communication and emotional regulation skills so that co-parents can cooperate and shield their children from their conflict. So we have to teach parents about their brains and child brain, and how their brains can get in the way of cooperating and what they can and should do to become and to do and to reason. So it creates us conditions to have support from a group that feels the same, that have the same experience. So in Portugal, we use that program as a first step when we do mediation. Why? Because we create the conditions for the parents communicate. So creates the conditions for mediations to be effective. And the first results are very, very stimulating. When we look, for instance, for the high conflict with child involvement, what we found is that when parents participate in that program, from pre to a post-test, what happened? The high conflict with child involvement, assessed with the acrimony scale, not just reduces, but is a high significant reduction. As you can see, we found a P with 0.002 and a Cohen-D about the effect size of 0.50. So results very encouraging to use that program when we need and we want to work with parents with high conflict. So as a conclusion, we need, however, to think that there is no credible scientific evidence that support that conclusion that all young children who have been exposed to significant early stresses will always develop stress-related disorders. Why? Because you know that there are protective factors that are acting and they can change the impact of the high conflict in the brain. So, but we can have the conclusion that in both animal and in human studies, intervention that provide consistent, predictable, and nurturing care help to stimulate positive adaptation and prevent poor outcomes. That we know for sure. So we know we need to work with parents. We need to help parents in order they can change themselves and not put always the blame in the other and expecting that the other change, because we can't change the others. We only can change ourselves. So thank you very much for your attention. It was really a pleasure to be with you, and I wish you a closing event with lots of success, and also I wish you all success in the future. Thank you very much.